Ladies and gentlemen, my name is Dr. Boris Schmidt. I'm working as a cardiologist at the Cardioangiological Center, Bethanien in Frankfurt, Germany. And today I'm talking to you about the management of patients with atrial tachycardias following ablation of complex fractionated atrial electrograms for persistent atrial fibrillation. These are my disclosures that you can see from the slides. So the type of recurrence that you face during a second procedure is strongly dependent on the index procedure. As you can see on the left-hand panel of this slide, usually we perform a wide area circumferential pulmonary vein isolation on our patients with long-standing persistent atrial fibrillation. But of course, as you can see from the right-hand panel, there are also strategies to ablate complex fractionated atrial electrograms in order to terminate the atrial fibrillation and convert it to atrial tachycardia or sinus rhythm during the index procedure. And whatever is done during the index procedure determines how the patient will come back and present to your emergency room. So in our experience, patients who underwent the procedure with ablation of complex fractionated atrial electrograms come back with either atrial fibrillation in about 60% of the cases or with atrial tachycardias in about 40% of the cases. And out of these patients who present with atrial tachycardia following a first procedure, 3/4 present with macro-reentrant atrial tachycardias, and only 1/4 has focal atrial tachycardias or localized reentries. So how do we approach these patients? We have to introduce a stepwise algorithm, and this is the first step. The first technical investigation that we do is to obtain a surface ECG, and during the analysis of the surface ECG we have to pay attention especially to the P wave. However, analysis of P wave morphology can be intriguing after complex ablation of the left atrium, so all the algorithms that you're aware of for native patients might not apply for patients who underwent a ablation of complex fractionated electrograms. The second thing besides P-wave morphology is P-wave cycle length, and I have two different examples. On the left-hand side, you see a P-wave cycle length that is highly variable, indicating or most likely indicating a focal atrial tachycardia, and on the other hand, on the right panel, you have a very stable atrial cycle length, indicating or making it likely that you deal with a macro-reentrant tachycardia. So after obtaining the surface ECG, you want to go ahead and get invasive diagnostics as a second step. And in order to analyze the atrial activation pattern, we prefer to insert multipolar catheters in the coronary sinus and analyze the activation sequence in the coronary sinus, whether it's a proximal to distal, which would be indicating a right atrial origin, or a distal to proximal activation pattern, which would indicate a left atrial origin of the tachycardia. Before we go ahead and perform transeptal puncture, we perform entrainment maneuvers at the cavo tricuspid isthmus in order to rule out common type atrial flutter. As a third step, assessment of the PV-LA reconnection or reconduction is crucial. And as you can see from this example, in this patient, we have a PV-LA reconnection at the septal pulmonary veins. However, the electrograms do not precede the P-wave onset, and we believe that this is passive activation of the pulmonary veins in this example. The next step, we try to understand the mechanism of the atrial tachycardia and, of course, the origin of the critical isthmus or the focus. And therefore, we prefer to put in multiple catheters into the left atrium to analyze the activation sequence. As you can see from here, we put in a multipolar catheter in the left atrial appendage, and we still have the coronary sinus catheter. And in this example, we performed entrainment maneuver from the left atrial isthmus close to the mitral valve and found a perfect concealed entrainment and a perfect post-pacing interval in this region, indicating left atrial macro-reentrant tachycardia and specifically a perimitral atrial flutter. But not enough with these pacing maneuvers. When you think of left atrial macro-reentrant tachycardias, there are basically two options after CFAE ablation, and that are those where the macro-reentrant tachycardia circles around the mitral annulus, and those where the critical isthmus is the left atrial roof. So that makes it a little easier that you have only these two options. In our case, we then performed a complete electroanatomical activation map, and as you can appreciate from this map, we confirmed our diagnosis of perimitral atrial flutter, and in order to be 100% sure, it's crucial to perform additional entrainment maneuvers and in at least two sides of the left atrium, and we would recommend to do this at two opposite sides of the left atrium, one at the lateral part of the mitral annulus and one at the septal part of the mitral annulus. And if at both sides the post-pacing interval is less than 30 milliseconds longer than the tachycardia cycle length, the diagnosis is confirmed. For roof-dependent atrial tachycardias, you should also perform entrainment maneuvers at two distinct sides in the left atrium, and this will be an anterior side close to the roof and a posterior side close to the roof in order to confirm the diagnosis. As a fifth step, we then ablate the left atrial macro-reentrant tachycardia, and as shown from this slide, we perform a left atrial isthmus line, terminating the tachycardia, and finally assessing bidirectional block across the ablation line by pacing from the one side of the ablation line from the coronary sinus, and on the other side pacing from the left atrial appendage and determining conduction time across the line to the coronary sinus. This is not the end of the procedure. As I showed to you, there was a PV-LA reconnection in the case that I presented to you, so the final step of the procedure would be to re-isolate all reconnected pulmonary veins in order to eliminate potential triggers for recurrences. However, it's not always as easy as shown in this example. Usually, patients with atrial tachycardias following CFAE ablation present with multiple atrial tachycardias that convert into each other before or during ablation. And this is one example where we also dealt